You can start, Dr. Lawson.
Sounds good. Good morning, everyone. It's my pleasure to introduce both of our speakers this morning. Our first speaker is Dr. Suraj Mishra. He's a third-year fellow and one of our chief cardiology fellows. Suraj is a Richmond native, growing up in the suburbs of Short Pump. He earned his undergraduate degree in biology and economics from the University of Virginia, and then completed a year of research at the NIH. Suraj earned his medical degree here at VCU School of Medicine, where he also served as the medical student government president and was inducted into the Gold Humanism Honor Society. He completed his internal medicine training at Temple University before returning to Richmond to complete his cardiology training. We are delighted that Suraj will be joining us in a few weeks as an interventional cardiology fellow here at VCU, after which he will be joining Virginia cardiovascular specialist here in Richmond, Virginia. Suraj, go ahead.
Thank you, Dr. Lawson. Hopefully everyone can hear me okay. So today, time has certainly flown over 3 years, and today is a very special day, I think, for Amr and I, as we give our final grand rounds. Thanks for being here this morning. Now, today there you go. I'll be talking about intracoronary imaging and the current practice and future directions. And obviously, there's quite a bit to cover in this topic. I wanted to do an overview of the current modalities that we have for intracoronary imaging, particularly intravascular ultrasound or IVUS and optical coherence tomography or OCT. And we'll recognize both the diagnostic and interventional applications of these tools and discuss what the future holds in intravascular imaging as a whole. Now, coronary angiography has historically served as the gold standard for diagnosis of coronary artery disease and also provides our guidance for our percutaneous interventions. And adjunctive use of intracoronary imaging has emerged really as over the last few decades as a complement to this conventional angiography, primarily to further characterize the plaque morphology and optimize our performances when we do intervention. Now, I like this figure quite a bit. It's from Nissen's paper in the early 2000s. And, what you'll see and what it shows on the left, a proximal LAD that we probably wouldn't give a second look to at all. But the more distal site, which is, shown here in the top right IVUS image, looks okay. But the more proximal site, which, if anything, looks better on angio, actually has a good size atheroma crescentic, but the lumen sizes of the vessel are same in both of them, which is why we kind of have this false negative, if you will, angiogram. And that's why utilizing intracoronary imaging, we can really truly see what lies beneath the lumen surface. And with lumen angiography, we're just looking at the tip of the iceberg, whereas imaging can help optimize our interventions. There's obviously so many applications to the current world. To kind of briefly overview, especially in our pre-intervention planning, you can assess your lesion, determine its size, morphology of the plaque itself. And doing imaging ahead of time will allow you to pick your stent size, pick the equipment that you might need, determine if the lesion requires atherectomy. And you can further optimize your results, especially to avoid underexpansion, malapposition, rule out edge dissections, and intracoronary imaging can also evaluate for stent failure and other complications that may occur. Now, when comparing IVUS and OCT, IVUS has overall greater penetration depth. The field of view is much bigger, and it can image through blood, whereas OCT, in summary, requires blood to be displaced by a contrast injection. But OCT's resolution is almost tenfold better. And in most cases, OCT and IVUS, these days are really based on personal preference, comfort, availability, cost. But there's some intrinsic characteristics where, particular imaging modality may be useful. A simple explanation that most of you know is utilization of IVUS for left main interventions, where the lumen's very large and may be difficult to clear it with OCT as you have to flush the contrast through. And with OCT, there's better near field of view and a better assessment of calcium. And this is because the infrared light can penetrate through the calcium. So you can measure the arc and the thickness of the calcium in itself. Now, when comparing IVUS and OCT, IVUS overall has greater penetration depth, larger lumen again. Field of view is much bigger and it can image through blood, whereas OCT requires that displacement. And Um, and so there's subtleties that are truly like a little bit different here. And so with IVUS, large vessels, osteal lesions, you'll be able to see maybe deeper plaques. And you can also image through lipid. Whereas with OCT, maybe you're focused more on really what's going on in the vessel wall. You want to assess stents. You want to assess complications. And OCT can really help with that calcium. So, as I said, I think there's subtle differences and uses for each of them. Overall, they're both fairly, adequate in doing your initial sort of assessments. Now, this is an example of IVUS, just the anatomy here that we're seeing. And what you'll see is the white circle indicates the catheter, and the green is really the lumen. And then the red is really the median intima. And that's typically kind of what you'll see in a basic IVUS image. It's not usually as straightforward. But some of the basic measurements that we're able to get through IVUS typically involve a reference point. So over here at A, and the most severe stenosis, at B. And you can calculate this area of stenosis by comparing, lumen to lumen, shown here at the bottom left, and get an area of stenosis. And then this is a little bit, another measurement you can do is, plaque burden, which is not necessarily the same as stenosis, but plaque burden shown here, where you compare the stenosis lumen to the stenosis external elastic membrane. And these are just, some of the various measurements that we'll use in the lab. Now, when it comes to plaque, IVUS can help characterize the plaque, to a degree. So on the left, you can see that soft, maybe soft lipid rich plaque, typically less dense, have lower echogenicity, as opposed to sort of the mixed fibrous plaque as you go towards the middle of the image. And then on the right, you see heavily calcified plaque. And obviously it's more hyperechoic and oftentimes has shadowing, beyond the plaque. And this poses a great limitation when we use IVUS occasionally, because we're not sure how deep this plaque may go. Now with OCT, you may already be able to tell there's greater resolution. You can see the media, the adventitia, the intima, and really the dotted green line there. What it shows is and really shows the lumen area, and again in the middle there the IVUS catheter. And now the blue line is really extending past the lumen, and that's really just showing the external elastic lamina, so really the entire circumference, including the wall, if you will. Now, similar in OCT, you can characterize the plaque in a more superior fashion than IVUS. And most would argue is actually easier. You can look to see if you're able to see entire, vessel circumference. This is from Dr. Ali's talk from, more recently actually at Sky, really kind of simplifying OCT for us. And if you're able to see the entire vessel wall circumference, and if so, then it's either normal or it's maybe a fibrous plaque where you can see some of the eccentric, intimal thickening. And now if you can't visualize the entire circumference of the vessel, then you look for the shadow and sort of the dropout. And if it's in the wall, and if it's diffuse, then it's typically lipid, you can see here. And if it's well circumcised, it's calcium. And then if the dropout's really in the lumen, which is more obvious here instead of the wall, which shows over here, then it's red or white thrombus. So it's a little bit more simple when comparing a lot of these IVUS films. That's some more examples. So in the top left in panel A, normal artery, pretty straightforward. Now panel B here in the top middle, you notice fibrous plaque, very, very, bright, signal rich, diffuse. There's not really a sharply delineated border per se. And you can analyze sort of the calcium depth here. And in panel C, in the top right, you notice definitely a more circumscribed lesion, right? More calcific plaque, sharp borders, and you can analyze the calcium depth, shown here with the arrows. And the arc as well is very helpful. And so here you can see that this, the 350 degrees means that, you're almost entirely, circumference with calcium. And so measuring the arc is very important because it really guides some of our atherectomies and interventions that we do. Now in the bottom left, you see lipid rich plaque, you see poorly defined borders. And because of the light attenuation, you can't really see the media of the wall very well. You can't, delineate between the different layers. And then, red thrombus here, if you look at the bottom right, shows obviously a lot of red blood cells, and therefore it highly attenuates. Because remember, this means complete absorbance of the infrared light. So that means that you can't really see past it. And that certainly sometimes can be a limitation with OCT. Now, most would say what we care most about is really vessel preparation. And vessel preparation is calcium. In calcified lesions, IVUS delineates the calcification arc, but not as thickness as we talked about with that dropout. This is why you see that shadow here. And in contrast with OCT, you can see both the calcification arc and also measure the thickness, which can really help guide your interventions in the type of atherectomy, as I stated. Now here you can see the angiogram on the left. I'm demonstrating a culprit lesion in the left anterior descending. And, OCT can be utilized in acute coronary syndrome. Now, plaque rupture can be identified on OCT really with great resolution. And you can see in the red arrowheads showing the disrupted sort of fibrous cap and cavity formation that's really inside the plaque here. And you can see this thin cap, sort of fibroatheroma that's kind of starts to develop, that was already obviously there, which just, typically shows that this is very much a plaque rupture. And you can see the rupture cavity and the residual cap fragment very clearly on OCT. So, OCTs certainly can, more sharply outline the rupture cavities here. Can really better identify and characterize the thrombus, and really if there is an ambiguous culprit, OCTs typically are imaging modality of choice. Now, just some other, applications of IVUS and OCT. This is a 39-year-old. No cardiac risk factors, found to have acute chest pain, inferior STEMI. Angiography demonstrated a filling defect here in the RCA, which you can see. And OCT demonstrated fresh thrombus. And yes, one would argue, well, you can't really see past the shadow, but this is actually more of a diagnostic tool. This is clearly fresh thrombus. And if you look just past the lesion or near the lesion, you can look at the wall at a reference point. And really, there's minimal pathological intimal thickening atherosclerosis. So this felt to be an embolic, event in nature. This is a 44-year-old gentleman who had childhood Kawasaki, presented with stable symptoms of angina. And you can see that there's clearly an aneurysmal LAD here. And given the large vessel size, OCT really couldn't measure the true lumen size and was unable to accurately, size aneurysm. And this is a case where IVUS is actually more superior because it's able to measure the 7-millimeter aneurysm that the patient had. This is a 47-year-old female with secundum ASD, Eisenmingers, presented with shortness of breath, palpitations. And the CT here on the left showed extrinsic compression of the left main from this giant pulmonary artery aneurysm. Urgent angiography confirmed severe ostial stenosis of the left main. And TIMI1 flow really down the LAD. And IVUS confirmed this dynamic compression of the left main, showed the extrinsic compression even in panel S here. And then, just passed it a normal vessel. So really the patient underwent successful IVUS guided PCI, and down here you can see the excellent result that was obtained. Obviously, IVUS and OCT are also very much important when we talk about planning and execution of percutaneous intervention. So stent sizing is crucial for minimizing these complications, reducing target vessel failure. You can see the cross section at the distal reference, the minimal lumen area site and the proximal reference are depicted, and measuring these sizing is very important. In the middle panel for minimal lumen area, you can see the external elastic membrane or mid-wall to mid-wall approach. And, this can be used on IVUS, but at this position, OCT actually fails to visualize the vessel boundaries due to limited penetration. There's a lot of lipid here, and so it's not able to actually visualize past that. So, in this case, maybe at this site, OCT isn't going to measure the lumen more accurately as IVUS would. The use of OCT really depends on the visibility of the external elastic membrane when trying to do sizing and so forth. You can also just size using the lumen-based approach as well. And this can be done with IVUS or OCT. It just depends on really how aggressive or how conservative you want to be when it comes to stent sizing. Now, I won't go over, each of these in detail, but when doing image-guided PCI, we employ multiple targets, and avoidance of stent under expansion is very important. And so use of, OCT use of OCT has sort of an automated lumen profile that can kind of quickly detect and calculate the minimal lumen area site. So you can see in the top left here, the distal selection, proximal selection of the vessel, and the automated sort of detection of the minimal lumen area here. And then it kind of spits out this number, and really the residual stenosis here is about 30%. And so therefore we need to further dilate this area. And so identification also of acute malapposition, or simply what that means is really lack of contact from the stent to the vessel wall, is important to recognize as well. So OCT demonstrates this by these red dots here. So it shows an area of malapposition. And this is particularly helpful in bifurcation lesions where this can certainly occur. OCT can recognize asymmetry, edge dissections, protrusions, which have all been, associated with adverse outcomes. Now, this summarizes post-PCI optimization targets. It was an article that came out in the European Heart Journal in 2018, which really was a consensus document. And, these include optimal stent expansion, absolute, as well as reference lumen diameter. And then avoidance of landing zone in a plaque burden of at least 50% or lipid-rich tissue. Avoidance of large malapposition, regions, irregular tissue protrusion, and dissections, and thresholds provided reflect really the consensus of this group. And some are based on consistent, some are based on robust prospective data, and others are just less established, just given it's difficult to study. And in summary, really intracoronary imaging is recommended for pre-intervention lesion and vessel assessment, peri-procedural guidance of lesion preparation and stent deployment, and post-intervention assessment of optimal endpoints and exclusion of complications. And these are from 2021's recommendations for guideline for coronary artery disease revascularization. And IVUS is useful for guidance, particularly for left main or complex coronary artery stenting. And OCT is also a reasonable alternative for peri-procedural guidance, except obviously an ostial left main. And in patients with stent failure, either IVUS or OCT can be very useful in determining the mechanism of this. And I do suspect in the next era, we'll see these becoming more of a class 1 recommendation in a lot of cases. Now, we know obviously intravascular imaging improves outcomes. Multiple randomized controlled trials have shown this, and ultimate IVUS XPL, Renovate, complex PCI, all of these are showing that IVUS-guided stent implantation was associated with lower rates of target vessel failure, lower rates of stent thrombosis. IVUS XPL, for example, has a reduction in MACE. Renovate complex PCI, lower incidence of composite death in target vessel when using IVUS or OCT. So really, a lot of these studies are showing that there's, very much good outcomes with this, which is why, obviously I'm talking about this today. But there's another area, especially when trying to identify high-risk patients. And we talk about plaque vulnerability. And vulnerable plaques are more rich in lipids with a necrotic core covered by a fine fibrotic cap. So near-infrared spectroscopy is another form of intravascular imaging, which generates this sort of chemogram. And what this essentially shows the probability of lipid being in that area, and high lipid content will be shown here in yellow. This is able to calculate sort of this lipid core burden index and really show what areas of the vessel may have lipid. And this has good applications in multiple different, settings. For example, acute coronary syndrome, where you can have a high lipid content, a thin cap. Or you can confirm stent thrombosis, where you wouldn't necessarily see lipid or in-stent atherosclerosis or anything to develop. These are just a few of these applications of NIRS. Now, this new trend of utilizing intravascular imaging to identify high-risk patients, vulnerable plaques, has also been published. And with the Prospect 2 trial, demonstrating that highly lipidic plaques by NIRS and large plaque burden are really independent predictors of patient and plaque level non-culprit MACE. And, so now there's this constant battle, and we talk about IVUS and OCT, and, when do we use IVUS? When do we use OCT? It's every fellow's question to Dr. Lawson in the cath lab, why are you using this versus that? And there's this consensus document that we published in the European Journal, and they were, very practical, essentially stating that both IVUS and OCT have essentially comparable outcomes. There's the same number of dots on each side. They have similar endpoints. Maybe some have subtle, advantages to the other, but they're equally effective in guiding PCI and assessment of the lesion. But there are some important differences. OCT has very good resolution, but at the cost of death. And some flush issues, for example, where you need to clear the blood and visualize with contrast. IVUS has poor resolution, but you have this advantage of death. And so at the bottom, then we look at other areas that can here that you see identify high-risk patients, and you have near-infrared spectroscopy, which can identify high-risk plaque precision. You don't really have the imaging capability. So therefore, NIRS has then been combined with IVUS or OCT. So for example, IVUS and NIRS have been, used and widely available clinically. Here you see a baseline angiogram of an LAD that really doesn't show any stenosis. And the NIRS IVUS kind of hybrid approach here indicates presence of plaque without really severe stenosis, but there's, a high lipid content here. The yellow kind of around the circle shows the areas of the sides of the vessel that have high lipid content, and obviously the chemogram shows that. But again, no severe stenosis really on the angiogram. Years later, follow-up angiogram shows clearly severely stenosed segments, further suggesting that NIRS in conjunction with IVUS can be a helpful diagnostic tool and really an early detection tool. Now, what's next? Now, what if you can have extreme resolution, ability to detect lipid using near-infrared spectroscopy, and also be able to look at large vessel size, have adequate depth, and essentially combining all three of these techniques of IVUS, OCT, and NIRS. And this was presented at SCAI this year, and this is a new hybrid approach called deep OCT NIRS, which really essentially is a deep OCT offering great resolution, maximal depth, in addition to identifying high-risk features and better characteristic of the plaque. And so on the left, you can see calcific lipid plaque, conventional OCT, and on deep OCT NIRS, you can obviously see a large difference in really looking at all the layers of the vessel, the wall, the plaque size, the calcium depth, and obviously the lipid content all in one go. And then here again at the bottom left here, conventional OCT versus deep OCT, really it's showing, confirmation of this lipid area where you can't really visualize that much on the OCT, but you're able to see it given the higher resolution penetration, and, showing that where the lipid actually, is visualized. And on the right, again, conventional IVUS and deep OCT NIRS, clearly there's a difference here in the resolution, better depth penetration, precision. And so really this new imaging there's a lot of workflow improvements as well. It's contrast-free saline imaging, no flush prep. You can have longer pullbacks, and there's AI-guided software, that help with decision-making. And so combining, greater depth penetration, enhanced resolution, the NIRS, and optimal imaging, system for approving PCI and assessing high plaque rates for, secondary event prevention is going to be very important. And so this has already been done in vivo as well. I'll end here. Hopefully this plays. It's just an example of the incredible resolution and some of the newer software that's out there for intravascular imaging, and, exciting to see what the future can hold. And, I just wanted to say that, thank you. And that concludes my talk. I want to take a moment and just thank you all for the experience I've had here as a fellow. It's impossible to express the gratitude I have really to all the faculty who played such a key role in every stage here in my education and training these last 3 years. And, I'm grateful that I've had the opportunity to be part of this great community of people here, and to GK, of course, giving me the opportunity and being a close mentor really every step of the way. Obviously as an early fellow, and then when I became a father, and how to balance being a dad and a cardiology fellow at the same time. And also, of course, thank you to all my co-fellows. It's such an honor to be part of such a great group of individuals. And, really these last 3 years wouldn't be the same. And to my class, a special shout out, especially, each of you, truly phenomenal people. You inspire me every day. And I'm just truly honored to graduate with you all. So thank you so much.
Great job, Suraj. We'll do questions. I don't know if Kelly or Vaishnavi is going to manage that, or if it's me, but I'll go ahead and ask you a question. which is that, the studies have all shown obviously fewer MACE events in imaging guided PCI, but they also show increased use of stents, both number of stents as well as length of stents in patients who have imaging guided PCI. Can you postulate why you think that might be, and if there's a downside to, increased length or sizing of stents?
Yeah, I mean, I think, increase just doing more stent. I mean, it's the more you see, the more you're going to be tempted to do, right? And so, it's kind of one of those things where, as we advance, not only in this realm, but other areas of cardiology, the more we're able to identify, genetic testing, for example, the more information we have, obviously that's going to bring more risk, bring more intervention. And I think that it's really on the operator to be very, to remember what the ischemia trial told us to go to these basic kind of approaches. I think, there's obviously a reduction, but the problem is, we're tempted and we feel that we have to do it. And a lot of these operators probably in the study are saying, well, if I do the stent, I can get the patient in the study and so forth. So there's a lot of bias, I think, that's also involved here. And I think that's where something like AI and these automated things aren't really going to, they're never going to take over really the human judgment. And I think that's important, especially us as trainees, to learn, when to actually intervene, when to not. Just because you get the information doesn't mean you have to intervene. And so I think the area that's going to be tough is the vulnerable plaque. Well, hey, this plaque might be vulnerable. How am I supposed to not intervene here and just be sure that this person's not going to have a plaque rupture or acute coronary syndrome in the future? And I think that's just your question brings up, but yeah, it's going to be a difficult kind of scenario.
Great.
Suraj, we have one question in the chat. It's from Dr. Contos. You mentioned that imaging is likely to be a class 1 recommendation. How often do we use it?
Well, currently, maybe not as much. I think that, looking into why we don't image more, well, it does take time. It takes cost. And those are probably two of the bigger factors. And most of the time you can get away with just using angiogram and guiding PCI. And it's one of those things that does take an extra step. It's like doing a limited echo versus a thorough echo, right? And there's downsides to kind of doing it. And I think that as imaging is starting to advance technologically and we're able to actually see the plaque and how much of the plaque is actually around the entire lumen wall. So the 360, we use orbital atherectomy. Those are sort of what I think will initially start being class 1, where it'll say, well, I'm surprised, for example, left main IVUS, that guideline is still class 2A, not really class 1 recommendation, but I think use it as class 1. So I think there's certain layers, and I think we're progressing to that. And I think the field is really starting to shift to that. And I think that it's really going to be about quality intervention, especially as the ischemia trial has really, we don't really intervene a lot, but when we do, we want to make sure that it's actually, making an impact and actually necessary. And I think, it's done in a quality kind of fashion. I think imaging is kind of utilizing that. It'll be interesting to see. I think coronary CTA, all of those measures will also be able to help detect vulnerable plaques. So we might have to go to intravascular imaging really to rely on that itself. But I think the question is I mean, true. And maybe Dr. Loss can speak to, why don't we use it more often? But I think costs and time are probably the bigger, reasons.
Yeah, I agree. I mean, there's definitely what you've already said, but there's also, time to adoption, right? So new technique, new technology, a decade ago or 12 or 14 years ago, first of all, it takes time for people to, agree that it's useful. You got to get the data to show that not only, yes, I can see something here, but how does that affect my outcomes? And then also training in it, right? So like the fellows that are graduating now have much more exposure to it. They're exposed not only to the utility of it, but then also to the industry education that's provided and the fellows courses and things like that. And so, as more people are trained in it, the adoption will increase further and the utilization will grow. But I think, most people agree that there are certain indications where certain situations where you will always use it, like in the left main. And then others where it's like, I'm pretty confident that I know what I'm doing here and I don't need it. And, how that will change more, I guess to be determined.
Mm-hmm.
Great job, Suraj. Our second speaker is Dr. Amr Marawan, who earned his medical degree at Ain Shams University, Faculty of Medicine in Egypt, where he graduated with honors. He completed his internal medicine training at the University of Tennessee at Chattanooga, and then joined the internal medicine faculty here at VCU in July 2017, where he practiced for 4 years. During those years, he participated in multiple clinical trials under the supervision of Dr. Abate and completed his MPH from Johns Hopkins School of Public Health. Amr then stayed for his cardiology fellowship and will graduate in 2 weeks. And then he'll move to Texas, where he will start his interventional cardiology fellowship at the Baylor Heart Hospital in Plano. Go ahead, Amr.
Thank you, Dr. Lawson, for your kind introduction. Good morning, everyone, and thank you for being here. Listen to our grand round. So today I'll be talking about coronary artery anomalies. Okay. So I'm going to talk about coronary artery anomalies and the threat they pose on our patients because of its association with sudden cardiac death. So I have nothing to disclose. So for the talk today, I want everybody to go home with two main take-home messages. The first one is to identify the high-risk features for coronary anomalies. That's one thing. The second thing will be to be able to risk stratify these patients so you can hold a discussion with your patient about what will be the individual plan for each one of them. So the overview for this talk, we'll talk about the types of coronary anomalies. Then we'll talk about a few definitions just to make sure we're all on the same page. Then we'll discuss prevalence of the anomalies. We'll discuss the epidemiology of sudden cardiac death. Then we'll move to the pathophysiology for sudden cardiac death in those patients. Then we'll talk about the clinical presentation and how to evaluate those patients with imaging, and then risk stratify them. And then we'll see what the guidelines has to offer in terms of management. Okay. So we'll start by two cases just to put things in perspective. So first patient we have is 19 years old, male college soccer player who has exertional chest tightness. He describes it to occur during exercise, especially at peak exercise, and it improves with rest. His cardiologist saw him, and then they ordered a stress test where he had a maximal stress test, and he showed anterior ST depressions. Then a coronary CTA was ordered, which showed that he has an anomalous left coronary artery that's coming from the right sinus of basalt. And the questions here were like, what intervention is needed, and can this patient continue to play soccer? Okay. The second case that we have is for a 50-year-old female who's a marathon runner. This patient, I think, saw her a cardiologist for prevention, basically. So they ordered a calcium scan, and the calcium scan suspected anomalous RCA from the left coronary cusp. The patient was completely asymptomatic. She exercises a lot. She had an exercise stress test, and she had like peak VO2 of 40 liters per kg per minute. There was no changes in the EKGs. She had no symptoms. And the question here is like, can she continue training and marathon running? So coronary artery anomalies I think it might be the most common congenital heart disease. And despite like having a lot of debate about the prevalence, it still poses like prevalence in the general population. It poses a risk in the young athletes because of the sudden cardiac death. So here, like as you can see, there's like numerous types of coronary artery anomalies. I don't think we can, remember all of them, but I think one thing to remember from this busy table is like most of these types are benign. Okay. And I like this shorter version of the types where it makes it more easy and practical, basically. So you can divide them by anomalies of origin, anomalies of course, and anomalies of termination. Okay. So the anomalies of origin, the important ones that I want to mention will be the anomalous origin of the coronary artery from the pulmonary artery. And this is very important because it's fatal. And a lot of these patients, usually you will meet them younger, they will have ischemic symptoms, and they actually have like heart failure. Okay. And the second one, which I want to mention, is the aortic anomalous origin of coronary arteries. And this one is like, I think it's maybe the most common out of all the types, and it's the one that's most studied, and it has a strong association with sudden cardiac death. And all the large, landmark trials in this field, that they identified the association with this type, with a sudden cardiac death. And for the rest of this talk, like I will be focused on this subtype, so aortic anomalous origin of coronary arteries. And whenever I say coronary artery anomaly, I basically that's what I mean. Okay. And just to clarify, when we mean that, so we mean that the right coronary artery is coming from the left coronary cusp, or the left coronary artery is coming from the right coronary cusp. Okay. Moving to the other type will be anomalies of course, and then one of them is myocardial bridging, which is pretty common, I would say. Another time it's benign, doesn't require intervention. And there's also anomalies of termination where the coronary arteries can have a fistula, like the cameral fistulas, where it drains in the ventricles, or it can have a completely extracardiac termination. Okay. So this is just here to highlight that the coronary anomaly, again, the anomalous aortic or coronary arteries can have also like some coarse subtypes. And the one that I wanted to highlight here is when the coronary artery comes off the cusp, it can run between the pulmonary artery and the aortic artery, and that's called an intra-arterial course. And that's a high-risk feature. So that's very important. There's other subtypes like pre-pulmonic, post-pulmonic, retrocardiac. Good to know, but I mean, the intra-arterial is the one that's also very important because of the being high-risk feature. So some definitions here. So coronaries get their name from the area they supply to the heart and not from their origin. So whatever coronary comes off and feeds the RV free wall, that's an RCA. If it feeds the anterior interventricular septum, that's an LAD. And if it feeds the LV free wall, that's a left circumflex. Okay. There's also what's called the normal variants, and these are the unusual anatomy that is present in more than 1% of the general population. And a common example for that would be having like separate ostia for the LAD and the circumflex. Maybe another example would be like if the conus branch is having a separate ostium from the RCA, that's another like common normal variant. So it doesn't have really any consequences for it. And in terms of anomalies, so we can label someone to have a coronary anomaly if it's occurring or if it's present in less than 1% of the population. So that's a coronary artery anomaly. Okay. So in terms of prevalence, the very first study that was tried to identify or try to understand the prevalence of coronary anomalies was done in 1956. It was done in Los Angeles. It was an autopsy. So they had almost 19,000 cases. They did autopsy for them, and then they realized that there was prevalence of coronary artery anomalies of about 0.3%. There was no preference for sex or race or anything. So 0.3%. 20 years after that, there was another trial that used, another study that used diagnostic coronary angiography, and the investigator studied 7,000 patients, and they showed that the prevalence is about 0.64%. 40 years after that, we have this excellent review where they reviewed like about 77 studies and like over 1 million patients, and they did show that the prevalence of coronary anomalies is about 0.44 if you do invasive angiography, and about 0.7 with non-invasive studies. You can think about it, it's still a range. Again, there's a lot of debate, so they think it's anywhere between 0.3 to maybe 0.7, the prevalence for it. And in terms for the epidemiology for the sudden cardiac death, so this is one of the landmark trials that was done in the field, and a lot of the guidelines and recommendations kind of like stem from this study. It was published around 2004 in Annals of Internal Medicine, where Dr. Eckert and his team, they studied, it was a retrospective cohort study. They looked at 6.3 million military recruits, where they were trying to identify those patients who had non-traumatic sudden cardiac deaths. They identified 126 patients. Out of them, 64 cases were because of cardiac pathology, and out of them, there were 33% or 21 patients died because of anomalous aortic origin of coronary artery. Okay, we'll get back to that trial like a few times during this talk. Another trial, so this is the largest autopsy that was done for sudden cardiac death in athletes. So over 27 years, they studied about 1,800 patients, and then they found that the first cause of death and first cause of sudden cardiac death in those patients was, of course, hypertrophic cardiomyopathy, and the second most common one was actually anomalous coronary artery, so about 17%. We have more trials. This one showed that structural pathology, specifically coronary anomalies, there was 14% of patients, which about out of 45 that was caused sudden cardiac death. Okay, we have few more lessons that we'll learn from these trials, from actually multiple of them. One of them is that the prevalence of the anomalous or intra-arterial anomalous right coronary artery was about 0.23%. On the other hand, the left coronary artery anomaly was about 0.03%. So the right coronary artery anomaly is about 6 to 7 times more common than the left. Okay. Another important point is that the left coronary artery anomalies are more associated with sudden cardiac death. So in the landmark trial that we mentioned, actually all the 26 patients who had sudden cardiac death, they all had left coronary artery anomalies. Okay, so if you have a left coronary artery anomaly, that's by default the high risk feature. So that's the second high risk feature that we mentioned so far. Also, most of these and for most of the information and the data we got is done in young athletes. So far, atherosclerotic coronary artery disease is the most common cause of death, most common cause of sudden cardiac death in athletes who are older than 35 years old. And the incidence in those for the coronary anomalies in those folks is still unclear. So when you think about the pathophysiology and the high-risk features, so in my mind, I kind of divide it into two parts. One is like having a high-risk anatomy, and then what will be the physiological consequences that leads to death or sudden cardiac death. So these are the top 5 features. One is having a split leg ostium, like pretty tight LED ostium here compared to the RCA. Having an intra-arterial course, like we mentioned, like running between the 2 major vessels. And in the past, like some of the traditional teaching mentioned that there might be a scissor-like effect during activity and exercise. Also having an intramural course where the coronary artery the proximal portion will run in the aortic wall. And there's also like the angle of takeoff. So you can see in this, like the bottom right figure here, like the LED is coming like straight out with like maybe an obtuse angle from the aorta. And if you look at the RCA, it comes off and kind of travels in a tangential course, make it like narrow or maybe more liable for like, ischemia, I would say. So these are the anatomic features. And then like, what are the potential physiologic consequences that we think of? So one will be like an increased cardiac output during exercise can lead to like obstruction of the split leg orifice, leading to ischemia and arrhythmias and death. Maybe the exercise may lead to increased pressure and volume during systole, which can lead to lateral wall compression of the intramural wall of the intramural walls. Another one will be like in extreme physical exercise. This can lead to tachycardia and shortened diastolic time, and this might lead to ischemia and death. So these are like some of the proposed mechanisms. However, there's a lot of discussions and debates because all the trials that were done in this space, we couldn't like replicate the results like accurately. And this reinforces the concept that ischemia associated with coronary anomalies is likely transient, and not consistently reproduced with exercise or provocative testing. And there's a lot of like work still in that field. So how do these patients present? So, I mean, think of any symptom for our patients who come to our clinic. They can present with chest tightness that resolve with rest. You can have dyspnea on exertion, maybe exercise intolerance, dizziness or lightheadedness. They can have syncope during or just after exertion. However, we have to keep in mind that absence of symptoms is not a reliable measure of like ruling that we have, so symptoms easily rule them in for high risk, but absence of symptoms is, does not rule them out from being safe. So back to our this landmark trial. So they looked into patients and the symptoms for those folks. So out of our 39 patients who had coronary artery pathology, only like less than 1/3 of them had symptoms. And when they looked at the 21 patients who actually had sudden cardiac death, about half of them only reported chest pain, syncope, or dyspnea. So half patients did not have any symptoms and they still had the same outcome. That's another trial that was done in Italy and kind of was looking at the same thing, trying to kind of have a clinical profile for these patients, the ones with coronary anomalies. And then they also discovered that about 37% of their athletes, only 37% of them described some chest pain, syncope, dizziness, or palpitation. And all have before sudden cardiac death. So unfortunately, sudden cardiac death is a frequent initial presenting symptom for the malignant anomalous coronary arteries. Okay. How to evaluate these patients? So, I mean, for everyone, we'll get an EKG, we'll get a stress test, and we'll get to that in a second. But I mean, like in terms of imaging and identifying like anomalies, so echo is a potential like good tool that we could use. I mean, I was so surprised to read that we can identify maybe 90% of the coronary ostia and the ports just with echo. So it's rapid, it's low cost, widely available. However, it needs a lot of expertise, like really skilled sonographers who can get that. And also, I'm not sure that we have like standard protocols to identify that. So when it comes to the guidelines, they don't recommend CTE for like, identifying the ostia, but it's just, part of the overall assessment for these patients. So what else can we do for those patients? So maybe we can do coronary computer tomography. So that's a class 1 recommendation, and actually the gold standard to identify coronary anomalies. It's relatively fast. Relatively fast, have good details, have good resolution for a good description of the course. However, like the kind of limitation for it will be like exposure to radiation and exposure to contrast, especially if these will be younger patients who would require more than one scan. So these are just things to keep in mind. Another potential test that we could do would be like cardiac MRI. So that's also have a class 1 indication in the guidelines. It's provide like some other additional information compared to the CAT scan, so they can give us some functional assessment for the heart. We can do like a stress CMR, for example, and they also identifies areas of fibrosis, which entail that these patients are like high risk because more prone to have like some arrhythmias. I think limitation that probably would come with a cardiac MRI will be it's I think relatively more expensive than the CAT scan. It's probably longer time than not probably it is longer time than the CAT scan, and especially in those who are claustrophobic, that might be an issue. And of course, like expertise and being available. So in large centers like here at VCU, that's not a problem, but in like a lot of other community hospitals, that might be an issue. So here we come to the risk stratification. So basically, we kind of try to put everything together and try to like understand, like label who was a high risk, who was a low risk, and what to do further. So you gather your information, you gather your history, you see the symptoms who have like chest pain or other potential symptoms, knowing that 50% of the cases will be asymptomatic. Then after that, we like start the imaging. So if we already identified those patients have coronary anomalies, the next thing will be to do an echocardiogram for overall assessment. You will need to get a CT or an MRI to identify the course exactly and like see if there's any other features that's important to know. And then for all these patients, we need to have an EKG, knowing that most of them will be like normal EKGs. And then we need also like a stress test for a functional assessment. And we can also get it as a myocardial perfusion test. So if we do that, then we can go to the right side where it's identify those who have no high risk. So it's basically asymptomatic. Maybe they have an anomalous right coronary artery with no ischemia and it's completely functional. So for these patients, usually you go down the route of like, we'll have discussions and share decision making. And, most of them will be able to resume their normal activities normally. And some of them, I think it depends on the situation, it might dictate some lifestyle modifications. But if we fall here on the left side where you have like symptoms that makes you like high risk by default, if you have a left coronary anomaly, again, makes you a high risk feature by default, we have any of the other anatomic features that we mentioned. So if it's left or right and have symptoms, then you automatically have to go for the surgical correction, or like you have to go this route. If you only have if you have some of these features and then you have a right coronary artery anomaly, but there's no ischemia, then there can be a discussion about what to do next. Another very useful tool, and last Suraj gave us like a good overview for that, is IVUS. So IVUS also have like a growing role in this field, and there's a lot of like recent trials that have recent studies that have shown how IVUS can show us like exceptional details about the stenosis severity, the extent of the intramural course. If there's any hypoplasia of the intramural course, they show how if there's any lateral compression. So it's a great tool that really adds a lot. You can use it early for stratification. You can use it like to kind of determine what will be the next step for the management for these folks. But of course, you have to keep in mind it comes with the limitation of first technical expertise and availability, and the second thing, it's a procedure, so it comes with its risk, and of course, radiation exposure. Moving on, we'll go to the management part. So what does the guidelines tell us to do? So the ACCH, I think the last guidelines came out in 2018 and 2019, and the recommended that for asymptomatic patients, require ischemic risk stratification with the stress testing. And if it's positive, all of them should be referred for surgery. So that's a class 1 recommendation, okay? Another class 1 recommendation will be for all athletes with coronary artery anomalies and they have signs or symptoms. They should be referred for corrective surgery. Whether it's right, whether it's left, they should be referred for surgery. And then like there's a lot of gray area in between. So it is accepted that any patients because this patient who had a left coronary artery anomaly can have an increased risk of sudden cardiac death. All these patients, we automatically refer them. It's not a class 1. I think this is a class 2A recommendation, but that's been the practice because, again, because of the strong association. So just keep in mind that, like we mentioned, like left has a stronger association with sudden cardiac death. It's about 6.3% compared to 0.2% only for those who have a right coronary artery, so almost 30 times more likely in some of the studies. And I think I like this algorithm because it summarizes like what they suggest in terms of like whether to go, the surgical route or other. So if you have a left coronary artery anomaly, whether you have symptoms or no, whether you have ischemia or no, we send you for surgery. The main difference will be, is it like a class 1? So if you have ischemic symptoms, if you don't have ischemic symptoms, it will be a class 2A. And then if you have a right coronary artery anomaly, again, ischemic symptoms, easy, go to surgery. If you don't have ischemia, then if you have some arrhythmias, like ventricular arrhythmias, so that might be also like require surgery, so also a class 2A. If not, then we can stop and think, like maybe we will do further testing, maybe we'll, because of some other risk features there that we might go for surgery, or we might just decide to observe and follow up for these patients. So there's some extra like recommendations maybe for the elderly. So we mentioned most of the studies and the information that we gathered were done in younger folks. So in elderly, there's some like others, suggested lifestyle modifications. One of them will be to avoid like extreme physical activity. I think it's not too hard to convince like people older than 35 years to stop like competitive athletics maybe. There's also maybe a chance for, or maybe a role for beta blockers, but these are all like, again, proposed. It's not, have like any solid, recommendation in the guidelines. And then like one last thing about exercise restriction and when to return to play. So for athletes who initially present because they were diagnosed to have a coronary artery anomaly, all of them should be restricted from competitive sports until risk stratification is complete. And for those who have a left coronary artery with an intra-arterial course, and whether they have ischemia or not, they should be prohibited from activity until surgical repair. And after the surgical repair is done, surgical correction is done, those patients have to stay away from competitive sport for 3 months, and then we can reassess. So after 3 months, we do like repeat kind of the whole thing again, see if there's any symptoms for those patients. We will do some imaging modalities for those patients, and then we will do some exercise stress testing or myocardial perfusion scans. And if there's no evidence of ischemia and if there's no symptoms, so those patients can return to activity, they can go back to their sports. They can go back to their sports. The other things will be, so if surgical correction is recommended, but the patient declined it, so those patients should be restricted from all kinds of sports, except for like the class 1A, which is basically like golfing and bowling. That's the only thing basically can do, okay? So I think that was my last slide. I think back to our cases like that we started. So for this young man who's playing soccer and he's very active and he's having symptoms. So what intervention? So he's clearly a high-risk person, like high risk because of symptoms, high risk because of the coronary anatomy, and because of the exercise stress test. So he needs surgery, this patient. And then can he continue to play soccer? Then, well, we'll see. So we get the surgery, stay away from competitive sport for 3 months, and then we'll reassess. If everything stays negative and he's in good shape, then he can go back to sport. If not, then we have to revisit and identify what needs to be done for him. And for the other case, for the 50-year-old female who's a marathon runner, so it seemed like this patient, again, she no symptoms, so low risk in that one. She have a right coronary artery anomaly, which again is a low risk feature, and like very active exercise stress test. She's excellent, achieved excellent peak VO2, no changes in the EKG. So I mean, kind of like checks all the good boxes here. So for this patient, we can have a discussion. Well, you don't have any significant risk that we worry about right this second. And probably she can continue her training. I mean, I think it's not unreasonable that this patient continue to do what she's used to, what she likes to do, with close follow-up, and of course with having low thresholds to revisit the plan basically. And I think that was my last slide. And I'm happy to take any questions.
Great job, Amar. I have a question for you. So a lot of times when we come across these anomalous coronary arteries and they are found to have an intra-arterial course or they have documented ischemia, we certainly send them to have a discussion with the surgeons. And many times the surgeons sort of cite age in their decision. So like, oh, well, this guy's already made it 60 years without a cardiac arrest, so I don't think that this warrants a surgical intervention, because if you've made it 60 years without this anomalous coronary artery being an issue, then I don't know that there's any benefit. In your research or in your preparation for this talk, did you come across anything that talked about age in terms of guiding your decision pathway?
All right, so I think the surgeon's statement is kind of fair statement. So those patients who have coronary anomalies and who probably will have symptoms early, like again, in younger folks less than 35 years, these are the ones who would benefit from having the surgery. If you check the high risk features, then yes, symptoms or like anatomy, it's good to address that early. But all the research that was done, we don't have enough data in older folks, like more than 35 years of age. But it seems like if you made it, like they said, if you made it to 60, why now? Why now is that an issue, right? So these patients will have more likely to have a atherosclerotic coronary artery disease, so should be managed accordingly. So like everybody else, you develop symptoms, you have some like plaque or some other risk factor that needs to be modified, or et cetera, et cetera. So we will address it like, according to that route, rather than just because they have a coronary anomaly that needs to be fixed.
It looks like there's two questions in the chat. One from Dr. Lesnevsky asking, what are the optimal surgical revascularization approaches?
There's like a few of them. I think the most common one now is unroofing, if I understand correctly from my research. I just thought that, you wouldn't go through the surgical techniques, but I think unroofing is the most common one done in this country right now. But I'm not sure. I don't have like the details of like the success or, preferences, but that's as far as I can tell from my research.
Yeah, so it's either unroofing or reimplanting, sort of cutting it out and reimplanting it in the appropriate location. Good. Okay.
Any other questions?
Amar, there's one more question in the chat box. Classically, anomalous RCA from the left sinus of Valsalva has been described in sudden cardiac death in marathon runners, points out variable exercise threshold. I don't think that's a question, but sorry.
So yes, it is described and it is there, but it seemed like the left coronary anomaly, left coronary artery coming from the right coronary cusp is way more common. So, like is I think almost 30 times more common. But yes, it definitely is there. It's a risk. And again, it's if you have symptoms, you have the features, you qualify for like, considering corrective surgery. Yeah.
Dr. Lesnevsky is saying that he took care of a 55-year-old patient with sudden cardiac death on treadmill in stage 2 bruise. Resuscitation was successful. Thallium showed anteroapical lateral septal ischemia. He declined surgery and unfortunately suffered sudden cardiac death 2 years later, chopping wood.
Yeah, it's again, it's we don't have sufficient data. So, I mean, I'm not surprised that we will run into some of these patients, unfortunately.
Okay, great. Thank you, Amar.
Thank you, Dr. Lawson. Thanks, everyone.